You're listening to the Physio Matters podcast in association with rehabmypatient.com, and this is session 85. Welcome back to the Physio Matters podcast. I'm Jack Chew, and what a whirlwind year we've had. Looking forward to reflecting on that in this show, and looking forward to 2021, of which we all hope, of course, will be more stable and better for everyone, including for the health of the nation and the health of all of our MSK professions, but particularly with being a physiotherapist by background, also being Physio Matters, also the core of MSK practice in the UK is delivered by physiotherapists, means that we do sometimes speak in physiocentric terms, although there's something for everyone in this show. And I hope you've enjoyed the content that we've produced through Therapy Live and also with our other collaborative network podcast. Do check out Massage Matters, At Your Cervix podcast, our women's health offering, as well as look out for Therapy Business Matters and You Matter, which is our self-care podcast for clinicians in these complex times, which are all going to be forming part of our Physio Matters podcast network. So many thanks for those of you that have tuned in this year, and also for following and supporting our content through various different means, including Physio Matters Plus. Check out physio-matters.com and check out the membership options there at just £5 a month. You can also find that through therapy-live.co.uk, which are, of course, the same thing, in that we can deliver the extra content and bonus materials, including all the recordings from all of our Therapy Live shows, as well as early access and a community of practice in which you can interact with the speakers as well as your fellow community members at just £5 a month with no contract. Massive thanks to Rehab My Patient for supporting Physio Matters ongoing. They've got some brilliant work on their exercise prescription software, as well as telehealth delivery integrated within that, including the fact that you can then give text and WhatsApp updates to patients for their exercise prescription, which, especially in the increased use of technology that patients have experienced this year, their seamless technologies have really helped to make this year more palatable and also persuade patients to be more versatile. It's really been something that we've witnessed them be more amenable to virtual consults, for example, because of the seamless technologies that we can provide them. So thanks to them, and do check them out for a free trial, rehabmypatient.com/Physio Matters. In this episode today, I speak to Alex Mackenzie, who's the Chair of Council for the Chartered Society of Physiotherapy. We do a bit of a review of the year in physiotherapy, the year at the CSP, a few of the interesting professional issues that have emerged, obviously a lot of COVID stuff, and latterly talking about some of the things that COVID has helped us to reflect on as to what we can kick on with in the future. As you might know, we usually do a reflections podcast this time of year, every year anyway, usually members of the team contributing to that, and we could have done the same. Felt like you'd heard enough from us this year. We have a Tune It Over podcast. It's daily weekdays now at 12:30. We've got plenty of opportunities to reach you, and you've heard plenty from us with lots of bonus episodes, etc. So instead, we decided to then reach out to Alex to see if she fancied talking about the year in review on a bit of a governance and policy level as well, because those are some of the interesting things that have occurred. Really appreciate that she came on the show at relatively short notice. And also that we really appreciate her style of being really welcoming to all conversation and discussion and debate, which is of course what we'd hope for in a chair of council, but also not many people know, and maybe we could have been a bit more vocal about it. We were very supportive of a governance change at the CSP a couple of years back, I think, which was that they slimmed down the council in terms of the amount of people, also decreased some of the factionalism that meant that people were representative of the whole of the membership. And also, with Alex at the helm, I can see there being far more reason for people to feel represented and also to get stuck in and to see a direct thread between what they want to propose and suggest and their voices being heard, and also then actions being taken, whether they're being enacted or at least getting accounted for, and that they can see that being acknowledged, which is something I'd encourage you all to do. We've heard from so many of you that are sometimes happy and sometimes frustrated with not just the CSP, but also just the way of the profession. And so we're certainly intending on doing more work with them in the new year through MSKR, and sort of, if you're a member of MSKR, then you certainly will know that we're going to represent you there. But it's just something that we would encourage you to get stuck in, get involved, engage, speak up, and then it's certainly up to Alex and team at the CSP to engage you and to hear something back, or to at least be happy with what you then find. But I certainly would say that if you feel like you've been disenfranchised for whatever reason before, then give them another try. It's certainly something I would encourage, especially under her helm. And I hope you can see from her discussion with me, and also, it's not my first interaction with her as a person, but also with them as an organisation this year, especially our elected council, are people that certainly are worth giving a shout, giving them a try. So I do encourage you to listen to this. Hope you enjoy it. Massive Happy New Year to you. Hope we all see a better 2021. We've got so much in store. It's very exciting. Last thing for me to plug, I suppose, is that we have our first Therapy Live event. Is Pelvic Health, which is certainly for MSK professionals, as well as your pelvic health specialists, covering everything from pelvic tendinopathies and pelvic stress fractures through to sort of getting back to running postpartum, back to the gym postpartum, a few different other more niche women's health and pelvic health issues that we're going to be covering over the course of 2 or 3 streams of education in March time. And those tickets are available, of course, at therapy-live.co.uk. And also just check out our social media for those. And we've got massive amounts of exciting stuff coming up in the new year, and so massive thanks to the team for keeping the show on the road and kicking on with new innovations as ever. And so thank you for listening, and I bring you Alex Mackenzie and me talking about a mad year in physiotherapy. I'll see you at the other side. Delighted to be here with Alex Mackenzie, Chair of CSP Council, to discuss a reflection on 2020. We're calling it a mad year in physiotherapy. And so really pleased to be able to grab Alex's time. We're recording this on the 30th of December. We couldn't have left it later. We were just seeing if anything else changed in this crazy year for us to make sure we could shoehorn it into a reflective podcast. Also planning to look forward into 2021 to think about what might be cropping up. Before we get stuck into all of that then, could you introduce yourself, Alex, for the listeners?
Yes, I am Alex Mackenzie, as you said, and I am Chair of CSP Council. I am a clinical lead physiotherapist based in Acute Hospital at Aberdeen Royal Infirmary in NHS Grampian, Scotland. So that's a brief summary.
Yeah, and we'll certainly get stuck into what that role has meant this year. When did you come into council?
I first started on council this time. I had previously been on council for a 4-year term. I then had a break for 2 years when I was lucky enough to be a vice president and chair of the governance review that made then the changes. So I came into the role onto council and as chair of council in April 2018.
Wow, so yeah, I think you've been in enough time for us to understand as to how this year might have been different in many which way. For the listeners then just tuning in, I think what we want to make sure we visit on this is going to be some big picture stuff, but there's also going to be some stuff where the devil is in the detail, and we will get into that. It's something that I think will be especially because of the year we've had, it's not going to be super physio-centric in a weird way. I think a lot of this will apply across the board in healthcare and in what our future visions are. And from previous conversations I've had with Alex in different contexts, I can tell that when it comes to the vision stuff, it's actually something that is very much for health of society, seems to motivate us both. And so I think we'll end up there. So I think there should be something for everyone. But I suppose before we've got stuck into the sort of almost relitigating every moment of 2020, which we'll have chance to, I thought I'd first ask what was planned for 2020 prior to it, and then how much of that was able to be enacted.
Well, yes, this time last year we did have some great plans. As you can imagine, it was the start of our new corporate strategy at the CSP. So that's 2020 to 2022. And we had 4 key aims within that strategy. They are building a thriving physio community, championing physiotherapy, maintaining an effective and sustainable organisation, and support members in their professional and working lives. Now, as year one, there were some things that we were just starting off with. We had a big plan for a community rehab campaign. But it's funny because actually overall, when we look at what we did achieve, we actually achieved quite a bit, even with that. But it was just what we achieved aligned to those aims was probably different to what we had thought we might be achieving.
Right.
So for example, supporting members in their professional and working lives, we did an awful lot of that through COVID, but it probably wasn't what we thought we might be doing. So, I think we've achieved a lot with our aims. There are some things that we had planned that have not been realized in the same way. But essentially, we did do quite a lot that actually work towards those aims.
And I suppose those when it comes to a new corporate strategy, as you say, within that 2-year span of 2020 to 2022, and I remember hearing a bit about that. It was actually I was on mat leave when I wasn't pat leave when the year started, and therefore one of the first meetings I took when I got back to work, and it was on Valentine's Day, was at the CSP meeting about sort of what MSKR was doing and what we were planning, and we were like sharing notes over what the strategy was, and also pleased to notice how much it was overlapping and where we could collaborate, etc. Little did we know, then I think it was, I honestly might say, on my train journey back up, I started to sort of smell a rat a little bit on this virus thing that people were talking about. And it wasn't many days after that, when I look back over my social media feeds, I was seen as a bit of a bit silly, really. I was sounding an early alarm, but the world totally shifted. And so that talk, and unfortunately, many of those actions we were never able to take up, because it was that rightly everyone's priorities shifted. So what key challenges do you feel the profession faced as the seriousness of the pandemic became apparent?
I think the first challenge really for members was knowledge. Knowledge about this new virus, what it caused, because it was causing obviously the respiratory conditions that came with it. I suppose it was that initial sharing of knowledge. We were having to learn fast what it meant to us, as were the doctors around. So it was, in some ways, there was far more MDT working in terms of that. I think, there was a lot about the kind of keeping safe, the PPE, the aerosol generating procedures. I think all of that was all in that sort of mixing pot of really early on challenges. Then sort of fairly quickly you add into that then what happened to private practices. Lockdown, I think, it was obviously a massive challenge, and a massive challenge for many of our private practice, independent sector, cancelling of services. I think all of that then had its own knock-on effect on the individuals as well. I think, when we're talking challenges, you cannot escape from the individual challenge this has been to everybody this year. And I think, from the work worries, the concerns, the income worries for people whose practices were affected, worries about family, about shielding for some people, about a whole range of things. It's just been a massive challenge, and I think in a way so unlike anything else, because you cannot separate the professional from the personal this year, because there's been so much there that has had that impact, and I think that's been a lot of the difficulty, because a lot of the concerns have been real anxiety worries for people, which I think are far harder to just deal with. When it's purely a work question, you can kind of deal with that, but this wasn't just work questions. People were having queries about things that were personal as well as related to work, from PPE, knowing what should they wear. If you think about what people were wearing in those early stages, we didn't have the kind of set protocols that are there now. There was an awful lot there that was concerning, and then and it's one of the big challenges, I think, in a way, the CSP has had, as well as members, is government was coming out with advice. Members then wanted to know what did that mean for them, but the advice maybe didn't contain that kind of information. So you had members really concerned saying to the CSP, what should we be doing, whether it's about private practices, should we be open, should we be closed? CSP is trying to find that information out. You've got staff trying to contact people in Department of Health or wherever else saying, what does this mean? What are you saying? And stuff wasn't coming out. So you had that kind of mismatch, I think, between what members needed and what was able to be provided sometimes, and the time lapse between initial sort of we're having lockdown to what does that really mean for for people providing healthcare out with the NHS, and I think that the time lag between the government saying lockdown to actually getting some advice on that was too long for many members. They wanted answers now, which is totally understandable. And I think that, again, because it was personal as well as professional, I think that was a big challenge.
Yeah, I think that the personal professional blurring, I think, is fascinating, and I no doubt will read books and beyond studies of this, where I realised it myself, where maybe took till autumn for me to realise I'm not, never mind first name terms with people. You're in first name terms with their pets, their children, their partners that walk across the screen now and again. That you just, if you're on a weekly meeting with the project you're working on, you're going to get to know each other in such different ways. The insides of each other's kitchens. It is everything. The whole positioning of the way in which we've all interacted has been so different. Means that it has blurred those lines. I suppose, do you want to think about that? The early times of the pandemic for the profession, and I agree. The first thing we both think about there is like the sort of safety concerns of staff and the actual doing of the day job and what our roles might be and how we can help. I loved that, and we all rallied to think, right, what is the most targeted use of our skill set. But I suppose one of the things that I noticed early doors was that, not necessarily always in criticism, but generally speaking, a call to the CSP to help, a cry for help from many in the profession. But what I felt was that there was then, for me, it shone a light on something that I'd long spoken about, which is that people don't necessarily understand the positionality of the CSP relative to their regulator as a membership body, as someone that can't necessarily tell you to do as much as maybe some people perceive that it should be doing, and they were almost expecting and wanting mandates and regulations from a voluntary members body. And that's something that I then found myself, on one hand, strongly defending the CSP in that, saying that it's just, unfortunately, you might want it to be, but that's not their job, and therefore it's not fair to hold them to those standards. But then on the other hand, and I tried to keep that hand hidden for a while because it felt more appropriate. But now at this point, I feel it's appropriate for me to say, but I told you so. Like, unfortunately, the CSP had set itself up a little bit for that, whereby it wasn't always necessarily clear in its positionality for that, because then its members not necessarily knowing its role in something like this, I think it made a rod for its own back. It didn't see it coming, of course, but I saw that juxtaposition happening very early doors. I just wondered if you'd reflect on those points.
Yeah, no, I mean, I think you're right. And I think it's back to that personal professional boundary almost. There is a difficulty, particularly where people are in private practice, so and their business is personal as well. But the CSP has always been clear that it provides services for the individual, not for businesses. But when the individual is the business, again, that's really hard to separate out, and I think that is an issue. And I think you're right. It's not been something that has ever really come to the fore, and not in any great numbers like it was this time. So individual practice owners may have come to the CSP and 2 years ago and said, what do I do about XYZ? And the CSP would say, well, that's business that you're asking. Physio First offer business sort of advice or whatever, but or else you need to go elsewhere. If you're asking a individual professional question, we can provide you with the answer. But what we had was whole scale people coming to us and saying, what do we do? And that's where I think you're absolutely right. And there was a kind of, I suppose, it was a sudden realization of a lot of people that's not what we provided when they thought it probably was, because what we do provide is for the individual. But when the individual is the practice, that is where the disconnect comes. I think also, when we reflect back, the communications to those members was probably not quite as good as they could have been. But then, in a way, our communication machine was working overtime for the members dealing directly with COVID to a certain degree. There was a lot of information. FAQs were being updated hourly at times. Whenever information came out, there was a lot of information being put out, but probably not for those members. Or there may have been 1 or 2 bits that was appropriate to those members in amongst 30 bits that were maybe relevant for people working in the NHS. And again, I think that when we reflect on that, there was ways in which we could maybe have done things differently, maybe have done things better. And that is something that we are sort of looking at in terms of how we communicate with sort of independent practice. Moving
that will definitely crop up later in the chat.
Yeah.
I think we can get into the detail there for sure. It was such a frantic time, and so I think that was where there were some understandable leeway being given, but also the pressing issue that people faced. And you're right about it does overlap so significantly, the personal and professional, especially when sometimes you've got so many sole traders. And I know I've spoken to others in the CSP that said that they probably did underestimate, that we can talk about engagement probably later on, but it's kind of that's not always known and delineated in statistics as to know just how many people are operating their own practice as a sole trader, and therefore there isn't massive differences between the personal and the professional. You can't. Isn't a hair's breadth between them. I suppose one of the things there that I look on, and I've reflected on myself in terms of the CSP's position, where looking after its members as individuals, it kind of then one of the reasons why I heard from business owners, or even not necessarily business owners, they're just people that work in private practice, but as an employee, they were then in a situation where they were surprised necessarily. It was the first they'd really noticed that they were a member as an individual, but then they were not necessarily able to think necessarily beyond that individual. Because when they worked, say, in the NHS, they witnessed the CSP look after them as an individual member and to have a rep that they knew of, etc. But also that every level beyond them, be that their team, if their team needed help and support, typically the CSP, especially on the union side, you can imagine, might champion their rights. If services were being questioned or challenged, then the CSP was there for that. And therefore, at a commissioning level, the CSP had something to say about their work in such a way that then, because that transcended their individuality, I think that's one of the reasons why people didn't necessarily recognize that then in private practice, that was why there was a disconnect. Do you think that's a reasonable assertion?
Yeah, I think so. I mean, I think it is one of those, and I suppose it's one of those assumptions that's made as well, that the CSP is more focused on the NHS than other members as such. And I think and part of that is as well, when you're talking about that macro level, well, it's easy to deal with an organisation like NHS England, and again, there is actually some slight disconnect in terms of what people think we can do, because we do stuff at the government NHS England level. But coming down to individual trust levels, again, we don't necessarily have that influence or that sway. When you come down to department level, we're back in with our sort of union support and things like that again. So it isn't straight the way through, but it does seem like that. And with so many members who work in the NHS, and I'm well aware that we have a lot of members who work in the NHS and work either private practice, independent practice, that people don't just necessarily work in one place, but we have a lot of members that do work there. And therefore, inevitably, there is a lot of focus on the large numbers of members sort of supporting them. So yes, I mean, I think you're right. I think there's a lot of assumptions that are made, because again, when you're working within a department, which typically has, stewards, safety reps, whoever, giving them support. And that is far less if you're working in the independent sector or if you're working in the private sector. I mean, we do have stewards working in those areas, but they are much fewer and further between. And with some of the independent hospitals, organisations, some of them don't recognise the CSP as a union, so we don't have that same input in that way. And I think that yes, there is, I suppose, again, it's more difficult to organise members in the way you would organise within a department when you've got 2 members here and 1 member over there. And at times, even within, physio only practices, on the whole, people then don't use the union side of it in the same way. And I think it does come potentially as a bit of a surprise when people don't have, I suppose, the same support system they think they should have, but it relies on, I suppose, putting those support systems in place in good times.
Yeah, and that perception thing, I think, is really relevant, isn't it? And I suspect we'll come to that, won't we, thinking about what 2021 might bring and lessons learned and stuff like that. So I definitely don't want to get too, we needn't get too stuck into that, because I think it will come from reflections and plans for how to better the whole situation. I suppose it's interesting that because of my this job means that I try and keep across these issues. Also, a bit of a sad interest in these things, also from a bit of a trade union background. My wife being a CSP rep of NHS work, and me I've always until recently straddled the sectors really, and don't typically wear a hat there. But it means that I think I then felt I had a unique insight and to the way in which the role, the responsibilities and how they were distributed. And in this instance, people's perception of what they'd been paying for suddenly smacked them in the face. And there were so many people I'd heard from that were CSP members. And then when you ask them as to why they're members, and they'd say, certainly for it's a simple way of me getting my insurance and the good rates for that. And they might even mention that they like the fact that the union's there for them if they need it. But generally speaking, they then, at a time like this, I think they expected it to be a more obvious source of exactly what they needed, and at a time where they struggled to. And we can definitely get stuck into that, I think, later on, because the perceptions being certainly something that communication is going to be key for. I think one decision that was made early on that's really relevant for us to zoom in on a little bit here, though, is that, from what I understand, it was made early doors that the CSP is going to be down the line in line with Government and Public Health England advice for what do's and don'ts are, right? The hard and fast, right? We're not allowing for spin, for want of a better term, and of course a really understanding principle, a total noble decision, and one that I'm not suggesting needs to be regretted. However, we know, though, that what happened there is that when said Government and Public Health England advice didn't necessarily give us the hard and fast that was required for members, that then did seem to put you guys in a funny spot, because you were, whereas had the decision of being, as other organisations had done, where they'd left a lot of room almost, which, you can understand that that's pretty dubious in many ways. It meant that they were a bit more versatile to respond quickly.
Mm-hmm. Yeah, I mean, I think, so our decision was based on the reputation of the organisation. So we looked at saying, what can we do, that maintains, I suppose, the reputation of the profession, of the organisation as much as anything else. So in terms of that, I suppose, if you take it as it's, take an example. So if we had said, you must shut your practice. So all private practices come, whatever date it was, the 16th, 17th of March, or whenever it was, lockdown, you must shut your practice. Which is what quite a number of people were calling for as well, saying, why have you not told private practices that they have to shut? And then, 3 weeks later or whatever, the government then said, no, you didn't need to shut. You could have kept going. That would have potentially, we could have had members coming back and suing us for lost income because we had given that advice. So we, plus, in terms of, advice about, say, PPE and things like that, again, we went with the government guidance. I've lost my word there. We lobbied, sorry. We lobbied for appropriate PPE. We lobbied hard when we thought that the government advisor got it wrong. But we still went with, what they said should happen. And again, because that's kind of where the legal side of things comes from. And I think, there is a reputation to say that we would do something that went against potentially what their advice would leave us completely at risk, and reputationally as well.
The
From
reputation of the reputation of vulnerability. So I don't think this is necessarily what you mean, but just in case, because I know that there'll be some listeners shouting down their earphones at me if I don't ask this, is that when you speak of reputation in that sense, and I understand what you mean, and I'm not suggesting it's not important, but it feels a bit like a country party before country type argument, in a sense, that there's like the symbolism of what the CSP has been, what it is now, what it could be, is something that is more precious than its constituent parts, in this case, members.
No, sorry. By reputation, I more meant in terms of, I suppose, giving the right advice, being appropriate, not, I suppose, not opening ourselves up to being sued because we had given bad advice. That sort of reputational side, rather than worrying about what we look like. It's not what we look like. I mean, but it matters that our members trust us. And I think that, whilst it was really, really difficult when we didn't have the appropriate advice, and some members did criticize us quite vocally about not saying, shut all the practices when lockdown sort of started. But we were working really hard behind the scenes to get that advice. But everything was changing all the time, and it was really, really hard to pin people down to actually ensure that we got something. In the same way that as people started opening up again, we had to go with what information we had, and not guess and not make things up. That actually it needed to go with what was the best advice out there at the at the time, what was coming through, what was being allowed.
Yeah, and certainly I remember early doors, it was frustrating sometimes to hear. It sort of merges to the prior point we were making about what is the role and responsibility of the CSP, and the legal precedents that would have then set that would have left you very vulnerable, and certainly it wouldn't have been there to support anyone if it had been what would have been equivalent of a class action taken by private practice owners. Imagine myself included if you'd have overreached to that extent, because it would have been clumsy. And also, unfortunately, even if the government were to then back that, the guidance at the time was such that there were urgent care needs, etc. Or you've got certain private practices that have a slim NHS contract, of which is an urgent triage role, of which definitely needed to not close. So if you close that practice and therefore someone gets cauda equina, that's going to be on your hands as well. So it was something that I was very frustrated at some factions that were making those accusations. And I think that the education for them was definitely sort of understanding that broader governance that they'd not really pursued and were being a bit rash with. Later down the line, though, and I suppose the vulnerability that I was mentioning earlier was kind of highlighted where, when things started to change and we started to end up into this, well, we're still in it, aren't we, COVID purgatory, right? Where it was like, it's not as intense a lockdown. And also we came to understand the virus differently, didn't we? Whereby the 3% death rate, is this the second coming of Ebola of a sorts, and its contagion being, predominantly surface transmission, etc. It was changing its behaviour and lifted out of the tighter lockdowns, of which things were a bit more clear cut, and also, whilst being that the mandating CSPs not being of duty to mandate, there was definitely, when you look at the Public Health England guidance, it was certainly face-to-face care needed to mean that you were very dubious, especially at that point when the disease was being understood better. It would have been dubious to remain open. But then beyond that, it started to get a bit grey. And then I think one of the things that I've had people ask me to make sure I asked is that when it started to get more vague, the individual NHS trusts and services and departments starting to make decisions over their demographics and how much virtual and stuff like that. It just felt like that they were naturally under more support with regards to governance, naturally internally. And the CSP, no doubt, supporting members in those circumstances. But just generally speaking, we understand that the behemoth that is the NHS means that they were likely to be supported there in a governance sense. In private practice, it did feel like there was then a natural disconnect. In fact, there were times whereby the government would announce something, and then when members then would go to the CSP for advice, it was even stated that we now understand that the NHS services can proceed. We're waiting to hear with regards to private practice. And on those occasions, that's where other bodies that are similarly positioned, because they hadn't been hard and fast to the government's guidelines, they were able to then state that we're confident that all our members can provide safe and quality care based on risk assessment and clinical reasoning, as they have done throughout this pandemic. And that there were no need for, like dentists, for example, were never needing to separate off sectors because they were able to not need to pass the government guidance as much because they weren't as tethered to it. At those points in time, were there some regrets at all where there was no play in the position, it left you a bit red-faced?
Yeah, I mean, to be honest, I wouldn't say it necessarily left us feeling red-faced, because that was what we'd stuck to, and that's what we said all along that we were going to do. So, in that respect, that is how we stuck to it. I mean, I think, in some ways, actually, with your reference to dentists, they were quite heavily restricted in terms, as guidance came out, it kind of allowed them to do a little bit more here and a little bit more there. But I mean, I think with it, although the NHS, opening up services, you might say was, I suppose the governance there allowed them to do that. Having been, I'm still a steward and part of a steward network, and I have to say, the questions that would be flying around when things were changing showed, there wasn't a lot of thought into it. A lot of the same kind of questions were coming up within the NHS, and I would actually love to pay tribute to the stewards and safety reps. Having seen how hard they worked during those early phases, trying to find out information for members, even, every time something changed, and even now, still trying to work hard for members. I mean, what it's like being, or, your wife being a rep, you're doing your own work and then this on top of it. And, there was an awful lot of questions still going around every time something changed. And even now, that there are still lots of questions sort of popping up that are all related to COVID, in some shape or form, people being asked to do certain things, and how should you, now we're in, level 4 or whatever, how should you travel with a student if you're doing community, it ranges from everything, so although on the surface and probably sort of looking in from the outside as such, it may look like, well, the NHS was just starting things up and everything, but it wasn't all plain sailing, by any stretch of the imagination. There was a lot of the same kind of questions, but of course they can be asked of the organisation that you work for rather than the CSP. So in some ways it was the same kind of thing. And I think, it was, in some ways it was easier for us. We said we would go with government, guidance. And I mean, one of the issues, of course, there was certainly, a Saturday when Boris Johnson decided to make an announcement, 6 o'clock on a Saturday. Well, of course, there's nobody working in the Department of Health to give us any answers until Monday. So on the Sunday, a lot of members, private practice members saying, what does this mean for us? And it's like, well, we haven't a clue, because all we've got is what was on the telly. We haven't got anything else. We've got nothing that gives us any background to it. And that was incredibly frustrating. And I'm sure, in some ways the civil servants were probably working hard behind the scenes, but they weren't contactable. We couldn't ask of anyone. So, it gave us a lot of frustration. But I think by being clear that we were going to stick with the government advice and we would wait until we got that advice, was a policy we took. I think communication, I think in terms of that, yes, we can always look at how we did it, what we did, how did we communicate what we were waiting for, and make people aware of why there was a delay between something being announced and getting advice. I think, yeah, definite lessons to be learned in terms of that.
No, it's a fascinating thing. I spoke to professional advisors in the summertime. Just as I'm not going to suggest that anything really truly settled, but it settled at least a little compared to the waves that we're now experiencing. But I remember a professional advisor said, just to give you a flavour of one of the questions, Jack, I was asked earlier today as to whether or not this member should continue to remain living with her children at the time. And it was just like, and you can so understand why that question would emerge and the complexity that's underneath that when that was unpacked. And obviously I didn't get all the details, but it was just this notion that, and one of several examples, of course, in that direction, whereby the personal had become the professional because of that understanding of what the guidance might suggest, means that is a complex situation to try and unpick. And certainly you're not going to get government guidance that suggests the answer to that very question. Now that brings to me then the notion of risk assessment and clinical reasoning that then was naturally expected and should be expected of all clinicians everywhere. However, it did mean that the pandemic, for various reasons, unearthed what, again, I'm sorry to say, something that we have kind of spoken about before on this show and beyond, about the fact that there are plenty of places to hide in many ways, not just in the profession, but across the industry, in MSK. And so you've then got a circumstance whereby clinical reasoning and risk assessment, which I would argue, and we all would hope, is at the heart of the profession, is probably still in principle, but then in practice, if you happen to have clinicians that have otherwise been able to keep their head down in safety terms, these aren't abusive people, they're otherwise well-meaning, they're not even realizing it, but they work above a hairdresser's, have done for 15 years, they've got a practice, they've got a bed, they do the day job, but generally speaking, risk assessment is something they maybe did when they first entered that clinic 15 years ago, maybe if they came through. And clinical reasoning is something that fundamentally they've sort of walked back a little bit because they know what works now and they see similar sorts of things. And I treat sore bits and this is what I do to treat this particular thing. And so it become less of a priority within their practice, let's say. And so I'm caricaturing a bit, admittedly, but we know that those happen to exist. They've been under the radar for a long time. They naturally then emerge seeking assistance. Their requirement for matter-of-fact answers in part is based on the fact that they're not doing the two key variables that you guys were asking of them. Was that a surprise for the CSP for those to emerge? And then what is the answer to that if we can try and come to a solution?
Yeah, I mean, I would say yes. I mean, I think we all knew there were probably some people out there who were like that. I think it was a bit concerning that the numbers that were coming forward and asking the very basic questions, like you say, we would say, well, you need to risk assess. And then they would sort of say, yeah, but what about in this situation? And it's like, you still need to risk assess, but what about in that situation? Yeah. Yes, I think that, that is a concern. What we do about it is slightly more tricky because, of course, we're not the regulator. So there is a responsibility, as an organisation, because we do represent the profession, that we need to look at those members and see, I suppose, how we can support them to, I'm going to say, be better versions of themselves. Like you say, they're clearly doing something right because their patients are coming back to them. But it is slightly concerning if they are not risk assessing and clinically reasoning in the same way that we would expect physios to do. I mean, I think if as ever, if there are clear examples of where somebody is not performing properly as a physio, then that's an HCPC issue. But and that's not a judgment we can make from somebody asking a question in a highly stressful situation, sure. And I think we need to be sort of fair to some of them in that respect, in terms of these are people whose livelihoods have been affected, who are highly anxious, who have potentially not worked near a hospital or anybody infectious or anything like that for a very, very long time, and are now having to deal with that aspect of it. I think that that inevitably will in some ways sort of bring out the worst in people. But I think this comes partly into how we potentially communicate with those members, how we would want to engage them, to try and bring them maybe more into, I suppose, into I suppose I'm going to say the more modern way of thinking of physio, to bring them into groups, to bring them, because I think it's back to that sort of peer assessment, peer support that helps people in terms of learning and developing and things like that. And I think that is a group that probably kind of, like you said, quite happily got their insurance, knew the CSP was there if they kind of needed them, but didn't really engage. And all of a sudden they wanted to engage and found it wasn't quite what they thought it was. And in the same way, you kind of think, well, if they're engaging now, what can we do to make, to help support them be as good as they can be, to be the good physios, I suppose.
And I mean, you made a really good point there about the fact that in those moments, none of us were at the best of ourselves. If I was, instead of the internal meetings where I was spouting nonsense, those weren't. They were on the phone to the CSP, of which I can understand why people might do that if they weren't able to have said internal meetings. You could so imagine that sometimes this style might be overrepresented somewhat in what we're thinking. I suppose on that point, it kind of brings us, I think, to a note I've made with regards to private sector stuff, which I think it's well worth us just getting into a second, is that that's where, granted, in ideological terms, it's not clumsy for me to suggest that trade unions typically are, whilst across sector, in healthcare terms, they naturally find themselves being bastions of nationalised health services, free at the point of access, certainly something that I'm passionate about too. But it's then in a situation whereby, if the CSP, and I'm interested in whether or not the CSP, or you might prefer to answer this as Alex Mackenzie, but in a system in which a system of healthcare delivery, is it, say, the CSP's position in which in an ideal world, the UK's health needs would be met by the state?
Okay, I'll answer that kind of probably more as an individual, in that, it comes as a surprise to nobody. I'm a trade unionist. I'm probably head more towards the socialist side of things and say, yes, I think everybody's healthcare needs should be provided by a national health service. However, that's not reality. The reality is that the NHS doesn't provide for every need. And to be honest, actually, even in my ideal world, it doesn't provide for every need, because there are some things that aren't, I'm going to say, aren't specifically health. If you're talking about sport improvement, things like that, that they are clearly related to bodies and therefore very much in our remit, but aren't what I would consider under, National Health Service. There are, the National Health Service is a limited budget because it comes obviously from taxes and things like that. Therefore, there is a market out there for others. And I firmly believe that there is way more work for all of us than we can provide in all our sectors. So yes, I believe firmly in the NHS as an organisation, but it has its limitations. And there are we're lucky. There are others out there who are private, independent, charities, all these other kind of sectors where people are willing to work and to provide for patients. And at the end of the day, that, to my mind, is the most crucial thing, that we can offer physio to everybody. Now, obviously, some people can't afford the private physio, and that's a political standpoint kind of thing, but actually, as long as we can provide within the NHS for those who can't afford, then those who can get it, elsewhere. There's convenience. I strongly believe that we have more than enough work for everyone, and we should, in that respect, be championing all sectors of physio, and we do, we do, and I know it doesn't always feel like that either
Sure.
for members.
Well, I think and that's great for us to hear from you. And I think that certainly the ideological and political positions of which are often on the side of appropriately nationalised healthcare means that you can then get what you're describing, which is then a pragmatic application of that to say that in the current situation, this is why we would be supportive of the whole. I suppose it's that there are people positionally, I'd even go as far as to say to the left of what you've just described, that then might be in a situation whereby someone seeking healthcare services for and someone then delivering said service, and then this profit on top of their cost there's a sort of immoral illegitimacy to that sometimes then internally within the CSP, for example, there's no reason why I'm suggesting that that's the policy ideology of the CSP. But again, when it comes to the sort of sector clashes that sometimes occur, the fact that those are, I just think that if I were to hazard a guess whether I could find someone who was of a persuasion that felt that there is an illegitimacy to profit in healthcare, and then finding someone that suggests that there is illegitimacy to taxation funded healthcare, I don't think I'd find that second person in the CSP. I can name you a few on the other. And so there is an ideological persuasion that naturally colours any organisation that's going to happen, but particularly one of which is naturally going to have a union bent and all the things that come with that. And I'm not even inferring in this instance that that's inherently a bad thing for any argument, but it's just more that because that exists, I think that I can understand why that colours people's sometimes understanding of what the CSP's motives are or what might be underneath their campaigning, for example.
Yeah, I mean, I think it comes from sort of two ways as well, because as I said before, the vast majority of our members work in the NHS. Doesn't mean they don't work elsewhere, but they do work in the NHS, and that in its own way brings that ideology. And I think you're right. You would find it hard to find somebody on the far right of your argument within the CSP, because you have to believe in the NHS, because the vast majority of our members work in the NHS. So you're really not going to get somebody in a way working for our organisation who doesn't believe in it because of those reasons. But I do think that, and I think when we talk about communications and we talk about action, and as somebody who lives and works in Scotland, the vast majority of a lot of the communications and things like that is based on NHS England. Now, again, that's the vast majority of our members. They work there, so when you're talking about sort of numbers and where information goes and where activity takes place, inevitably, because all our members pay their membership fee, you will get it going to larger numbers, to a certain degree. Now, that doesn't mean that we shouldn't forget about others, and it doesn't mean other people come lower down the list, but there is I suppose a kind of not prioritization, but an inevitable way that a certain amount of activity takes place because of numbers of members who work in a certain area. So and it does feel sometimes like, and I have, people I work with who'll say, it's all about England. And it's like, well, it's not all about England. There are other things, but you have to remember that's where the vast majority of people work. So it's a real balancing act for the CSP. And, it is something, as I say, looking forward, if we can start looking that way, we are trying to look at in terms of, how we communicate as much as anything else with those other areas. And, I did say, having just been obviously re-elected as chair for another 2 years, that's one of the things that I'm wanting to look at, is those groups of people who feel their voice isn't being heard. So trying to find ways to get those people to feel like they are being heard, or maybe listening, I suppose, making sure that we're hearing them so that we can work out how we best address that. Now, it doesn't mean that everything they ask for is going to happen. It doesn't mean, all of a sudden there's going to be heaps of stuff coming through, based around them. But it's important that they feel that we are really hearing what they're saying,
Right.
that we're taking that on board when we're making decisions, if that makes sense.
Yeah, it does, absolutely. And I think that that's where the sort of the pragmatic side, whereby you're understanding the level of where the members are distributed geographically, therefore where and also, like you mentioned, about how where the members are distributed across sector, is that those numbers do matter. And it's also the argument that I'm often making where physiotherapy, us being physiotherapy centric in some of our MSK reform policies, is that we've got the majority of care delivery in MSK being physios, just on a pragmatic level, means that sometimes that accusation is something that people aren't looking to the numbers. I suppose it's just out of interest, and certainly something that I'm looking forward to 2021, is that it be not just for the CSP, but just as a profession, or as healthcare more broadly, especially when I'm thinking with my MSK hat on now, just generally, where we understand why people might be pragmatically biased in a direction because of the numbers, as we've just described it. But much like we wouldn't be comfortable with ideologically people being Anglo-centric at the CSP by suggesting that, but pragmatically can understand why the numbers might fall that way. But if there were people making no, that's just where the majority is, therefore we're going to make, you get English-centric policy that then bleeds out. Whereas, generally speaking, I can understand that people might be concerned that the CSP would be ideologically public sector centric in such a way that then the private practice side, or the independent sector, of which of course is growing and bleeds into charity and a few different things. You've mentioned crossover members across different, amazing how many portfolio careers people are building in various different ways. And so we want to make sure we try to understand that the pragmatic doesn't necessarily mean that it carries with it an ideological bias that then means we're underrepresented, and engagement is the key answer there. And I think that's going to be one of the conclusions we clearly come to, is let's get stuck in, let's try and make sure we collaborate to work together, and to make sure that then all voices get heard. But you made a good point as well, Isabel. Don't mean that those voices are right, don't matter where they're coming from. Let's discuss it, let's debate it, which is obviously what we're doing. I just want to give you an opportunity to say, like, what were the key issues do you think 2020 has brought to light, as well as obviously then how that looks forward into 2021?
Yeah, I mean, I think, I think it's brought a number of things to light. I mean, clearly, there's a fair amount that we've talked about in terms of specifically our relationship. If we're looking sort of CSP level, our relationship with private practice, with the independent sector, I think that's brought a certain amount of that to light in terms of how we deal with that. I think some of the really interesting thing, there's always that saying, don't let a good crisis go to waste, which sounds a bit flippant in this COVID time, but I think it's really important that we look at what those changes that have been enforced on us, what good has come from that. I think we've the worst phrase ever is we've always done it that way, and I think there's so many advances that have been made, some of the technological advances, some of the ways of interacting with patients, that we shouldn't just slot back. I think that there's an awful lot of innovation that happened this year that had to happen, because otherwise patients weren't going to be seen. I think there's a lot within that. And then of course, for me, one of the big things with 2020 has to come from the Black Lives Matter movement that happened in that came more to prominence, I would say, within 2020. I think it's shone a light on our organisation, it's shone a light on our profession, and I think it hasn't shown us in the best of light. I think looking ahead at diversity generally, it's something that obviously with on council, we don't have any visible diversity. So that's typically obviously with our Black and Asian minority ethnic members. We know as a profession we don't represent the population. And I think that's across sort of generally across the board. Obviously that comes with our BAME members, but also some of our sort of members with disabilities. I think that we can do a lot better with that, and I think looking forward, obviously we are producing our equality, diversity and inclusion strategy, which will be out for consultation early months of next year. So it's in its draft form, or its drafting form, and to my mind, that's something that we as a profession, as well as an organisation, we need to look really long and hard at ourselves. I think that to my mind it was a massive wake-up call for us, and I think that by shining the light on that, by addressing our racial issues that we now are beginning to understand a little bit more, will make us a better and a stronger profession.
You know, you said it shone a negative light on the profession, or the racial issues we need to be aware of. Are you meaning the statistical differences between the say trait groups of where we're not representative of the population of which we serve, or were you suggesting that there's something then that comes from that is kind of what the issue is?
I think it's both. I think we're not representative of the population. We have better numbers within the students coming in, but that's slightly a kind of drop in the ocean when you look at the profession as a whole. But I think that there are issues within our profession in terms of Black and minority ethnic people being able to get ahead. There's quite a number when you listen to some of the stories that have come out, the podcasts that have been produced this year by our Black and minority Asian ethnic members. It's been quite shocking, some of the stories that they're telling. It doesn't shine a good light on the profession that some of these practices are still happening, and I think that there's a lot that we as a profession need to do in terms of looking at the organizations that we work in, and that's all of our organizations. We know that structures and processes are in place that just limit how far these members can get on, the barriers that they face, the racial prejudice that they face, and that isn't necessarily overt. For many of us, we need to look at our own racial prejudices that are inherent in us because we've been brought up in the society that we're in. So these aren't things that we necessarily, I've never classed myself as a racist. I've always been, really open to not being racist, but I realized that isn't good enough. I need to stand up and be anti-racist. So you need to look at structures and processes. What's limiting people? What are the factors that are creating barriers to these members being able to access the profession, to be able to get ahead in the profession, and actually then when you start looking as a profession, the health inequalities that come, from BAME people. We know, COVID has highlighted it, and some of these are social structures that are in place. But as a profession who cares about health, they're things that we need to be looking at and campaigning on and addressing. And it's easy to try and take on the world, and we need to look at ourselves though to start off with, and really I suppose drill down into this and to understand ourselves, to then be able to make changes.
Would you say that the profession, as you're describing it, like the profession is racist?
In that respect, I would say yes. And by that, I'm meaning the structures and processes that are in place limit how easily Black and minority ethnic people can get ahead. And you only need to look at, again, the fact that we haven't got that many joining our profession. says something to start off with, because I can't believe, like with anything, you can't believe that actually they're not applying. So how are they getting in or not getting in? We need to look at it from that level. We need to look at how many Black professors are there, how many Black sort of leaders, how many, or BAME, I should say, where are these people at the higher levels? Where are these people in making decisions? Because they're not very visible. And some of that is because we just don't have the numbers within the profession. So that brings us back, and that's using racist in the terminology of meaning the structures and processes are inherently racist. Not that individuals are, it's not intent.
That's the relevant difference between individual acts of racism and systemic institutional racism.
Yeah.
But that one of the things that then is challenging between those things is that, are we making a mistake of inferring causation from a correlation, in that you can get statistical, without a thorough analysis, then it just seems like potentially a bit of a jump, whereby you can get statistical inequities that then, when we drill down to each level of it, if you notice that, as you mentioned there, imagine that there was a representative population sample applying into UK universities, yet at some point of the screening process, you've then got a massive drop off in BAME applicants that get through into university. Like, you're able to sort of hone in on what is it about that filter that's being either overtly or covertly bigoted.
Yeah.
But let's say, because from what I understand, and we've had a roundtable discussion on physio matters as well as Melrose Stewart on the podcast earlier in the year and stuff. And so from what I understand is that you've then got applications far lower than population, and then everything beyond that, including leadership, which you can understand. So then when it comes to something like that, you've then got so many variables at play that part of one of the features at play of that might be, well, that for various reasons, the BAME community are not necessarily even applying, doesn't necessarily, that doesn't inherently suggest something of the profession itself. I mean, there might be lessons to learn there, but they might just not want to be physios. And some might argue, good on them, they might have ambitions beyond physio. They might actually, and we've heard from some, and it was funny because Melrose, I think, mentioned this, is that, and also on the roundtable, it was discussed as that it was that they were pitching to be doctors and things like that, and certain portions of course, the BAME community managing to be overrepresented in medicine in many faculties, etc., which is of course great. But I'm sort of wondering as to whether or not you see a potential for us making that correlation causation mistake if we're not careful and thorough with this.
Yeah, I know. I fully agree. I mean, that's something that there's more information that is required. But we do know that it is, people apply for things when they see people like themselves, and that the difficulty is seeing people like themselves within the profession when they're not there. So that there's something within that. But I mean, from my point of view, sort of looking and being, feeling confident in saying that, as a profession, we need to change, we need to do something, is also and again, it's anecdotal, but it's listening to members' stories. And that's where I think that, to my mind, because otherwise you can, sort of say maybe it's people aren't wanting to apply, but when they have applied, then are they staying in the profession, and where are they staying in the profession, and what difficulties are they finding? And when you listen to the stories of members, you realize that they do not have the same career journey that the rest of us do. It's not as easy. They come up against obstacles that we would never face, and it's hearing that repeatedly that has made me feel really strongly about having to change it, because we've got young, enthusiastic physios who could easily have dropped out due to what they faced, and we need to change that.
More so than other professions, you feel?
It's difficult to necessarily compare ourselves to other professions, because we know that there are significantly low numbers across most of the AHP professions, which would be our kind of traditional benchmark. but I think we need to look at ourselves first. I think the comparison doesn't always work quite so well, because we need to look at what are we doing? How are we doing? And we've got some amazing, fabulous BAME members, and some of whom have made it to the top. We've got a couple of consultant physios, from the BAME community, but they've kind of got there in spite of everything, rather than, so they've had to probably jump through more hoops potentially to get there. And again, when you talk to them, they have faced a lot of challenges that the rest of us never face. And to my mind, that's where we need to be looking and changing.
Yeah, I suppose it's more, my question with regards to isn't to be relativistic about it across profession. It's more that the level of where the attention is required is going to be relevant to whether or not this is this physiotherapy as it's situated in society, meaning that there are certain attitudes and prejudices that need to be addressed, that then physiotherapy is seeing its slice of, or is there anything inherent or unique to physiotherapy relative to other professions adjacent to it that is making quite specific mistakes? Because then that level of analysis is going to be relevant to what changes we might want to instill. And so those anecdotes that emerge, and I've heard them myself, and including again from the discussions that we've been having on and off air with some of our contributors. It's been fascinating and disturbing that those things still exist. It's when we're trying to then tease that out to know as to, are these, because if those tales and stories are overrepresented in physiotherapy relative to, I mean, obviously you'd say in healthcare, but even relative to other professions, then that's something that is a deeper rot than any of us can accept. And also, I wondered if you were aware of any evidence of that.
Simple answer is no, I'm not. I mean, I don't know where we stand in terms of others. It's not something that in its own way we've looked at. What we've looked at is ourselves, really, because I think, from our, I mean, I think that's a very valid point. Are we worse than anyone else? But whatever, we've got to change. So we need to make sure that those kind of incidents, those the structures and the things that are in place that add to that are what we need to look at. And it's, it's a big project. It's not, our EDI strategy is not going to be 3 years like our typical corporate strategy. It's more of a 5-year strategy. This is trying to get sustainable change. But no, in simple terms, we haven't done it as a comparator. We've just looked at ourselves.
And I think you're right in that a comparator can sometimes be deflective from the fact that there's certain immediate changes that are closer in proximity. Therefore, sometimes I won't even say easier because it's a complex topic, but they're things like, well, if you can do this, then why wait around for the rest to follow suit? Because it's only going to elevate everything. I suppose it's more that we won't want to succumb to the narcissism of thinking that there is something unique, if that is something that actually it's something on a level beyond that needs to be changed and reflected on, and that the prejudices it's our representation of said prejudices on a macro means that we could end up getting navel gaze a little bit, and therefore miss the opportunity to actually make positive reforms in opportunity for people, which obviously again we're waiting on, and no doubt we'll do all we can to broadcast and of course appropriately critique the EDI strategy as it emerges, to try and understand as to how we can get that positively move forward, and making sure that that's something that then does achieve what it's setting out to. I wonder you mentioned in your, I think it was in both your remarks at Physio UK and your final remarks at I think it was a newsletter address to members this year. I think you've rung a bell because you've just mentioned it again. There is that it's no longer okay to be unracist, but it's important to be anti-racist, and that's something you reflected on yourself personally, and you were feeling you said in the newsletter, as a profession we need to do that. I suppose I recognise those terms as they emerge in Sabre and Kendi's work. Mm-hmm. However, it's sometimes for someone that's less literate in that direction, it sounds like as if the profession isn't anti-racist already, or the professionals aren't actively pursuing and would call out racism where they find it. I wondered if you maybe try and parse those terms for us.
Yeah, I mean, being not racist is simply, not on an individual level judging people related to their racial background. The point about anti-racist is actually actively working against those structures and systems that create racism. And so, when talking about the profession needing to be anti-racist, it means each of us does need to see, and it's not about the overt. I would hope that being not racist means that you would call out a racist act, an individual kind of racist act. So if a patient is being racist to somebody, that you would go in and call that out. But actually, it's more than that. It's supporting, working with our BAME members to make substantial changes to the systems and processes that are in place that may limit how they can progress, how BAME communities access healthcare. It's across the board, and it's. I mean, I do, and I referenced it at my Physio UK speech as well. Stephanie Nixon's paper on the coin model of privilege is a fabulous read in terms of describing our privileges that we hold as individuals. And this is one of the tricky things with it, is it's actually, it is very individual in terms of you have to look at yourself before you can go out and help make changes and do things. But it's understanding where we hold privilege, and that's in terms of unearned betterment, or not, or unearned detriment, depending on which side of a coin you sit on. So, if you are white, which I am, I hold a privilege that means that I don't have to face racist issues at all in my life. So it doesn't mean my life, is easy or anything else, but that's not one aspect of it that is difficult. And when you talk about sort of privilege generally, you can also look at things like ability versus disability. There's a whole sort of range of things, and it's societal as well. So you look at how society is set up for the normal, and if you don't fit into that normal, then you have certain disadvantages. And I think that particularly as healthcare workers, we need to understand this a bit more, because our patients come with this as well. So our patients come with a background history of what their life is, and there'll be aspects of their life that are privileged, and there'll be aspects of their life that are not, and they will have, for those bits that are not, they will have influenced the way they can live life and the way they can access things, and by understanding that, and by understanding our BAME communities, and working with them, and that's a really important thing, is that will allow us to create better health services as well. So I think that it's such an important topic that we need to start to look at, because we're very good at deciding what we think is the best thing, but it's actually that co-production, it's that working with, and I think that in terms of that, we've not looked at it really as a profession. Individuals might have looked at it, but generally I think this is something that it takes whole scale change, whole scale rethinking. I think it was Stephanie and who said maybe we need to reimagine the profession, and I think that's something that's really helpful if we start thinking on that level.
I've got a few things that I just wanted to make sure I touched on before we go. They can be quicker fire, although they needn't be if you want to unpack them. But there's been a few questions coming in from, again, the independent sector as to whether or not they feel that the CSP is going to help them to be considered in the same round of vaccinations as their counterparts in the NHS. Is that something that you guys have given thought to?
I'm going to be upfront and say we haven't had a policy on vaccinations. Obviously, this is something that's come about really in the last couple of weeks. We don't really have influence over who's vaccinating, because and the 4 countries are doing it differently. I know, in Scotland they are vaccinating the healthcare staff first off, whereas they're not in England. I don't think. I think it's a variety of things. Obviously, we would be pushing for any health staff to be able to be vaccinated, and and dealing with, obviously, with the public, that would be, to my mind, a very logical step to be taken. I'm not sure we're going to have any influence over this. Doesn't mean we won't try, but normally our influence takes time, and obviously the vaccinations are happening now. So it's probably not a really helpful answer, but we don't actually, apart from the fact that we think all healthcare staff wherever they work should get vaccinated. I don't think we haven't really got a policy on it. Obviously, I think first off we would be looking at those who actually work directly with COVID patients to be able to be vaccinated. But yeah, I'm kind of, I suppose I'm talking my personal preference. We don't have a policy on it, and it might be a difficult one for us to influence, but doesn't mean we won't try.
Sure. Yeah, no, that'd be interesting. And of course, I think that's where, in principle, I think people would be pleased to hear that, and also pleased to see that, is that if the CSP's position is that there should be parity, then the fact that if that was deviated from and then challenged as best possible, even if that wasn't directly going to be easy to influence, which it no doubt won't be, I imagine that would be meaningful for people, symbolically at the very least. What does it mean to be and to have that engagement process that can be more thorough? Then I think people will be able to do that. I can think of examples in a council setting whereby, imagine if your CSP council chamber ended up being almost like a US Congress chamber, in which on a particular issue you had, but experts turning up as talking heads on Zoom, that wouldn't be necessarily appropriate to have spent the day on the way down to your head office in London, but might have been able to participate and give their take on a matter of which they've particularly have a considered opinion that is contrary to another considered opinion that's on the shared screen, and to truly discuss that, and the opportunity for that true participation into issues that then we all know matter, but it feels like necessarily over the years have occurred behind more closed doors than people would like to see in front of them, and truly start to represent what is meant as a talking point sometimes, or appears as a talking point. We are the CSP. It's sort of like, well, yeah, I am also the government, but it's sometimes there's a distance between me and it that sometimes is apparent, that doesn't make me feel necessarily well engaged. And obviously we're smaller in size, that makes me feel that that's a more practical way of feeling engaged, is that if we use digital tools, as well as the goodwill that you and your other fellow council members are looking at for us to be more involved in every voice counting, I sort of that's my 2021 hope for the profession, is that we can not only just be more engaged and more vocal, but also that there are then those routes to change, be that as quick as could be sensible.
Yeah, I mean, I think you're right, and I think one of the key learning things that we've had from this year is how we can do things differently, how we can reimagine the way we do things, and one of those, I have to say, was actually like the AGM. We held a digital AGM. We were a little concerned because normally it's held at Physio UK, because that's an event where we hold it. We have talked about maybe moving it to ARC, or see where it sits well. But we're chorus at 50, and we were a little concerned whether we would get 50 people wanting to turn up, and we had over 200. Great engagement from the membership, to actually turn up to the AGM, to be able to ask questions, to be able to hear what went on, what plan is, things like that. So that was something that we didn't expect necessarily to achieve what it did achieve, I think. I mean, obviously it achieved the procedural things, which is what we had to do, but what we also had was a platform to actually engage members, and to inform them of what had gone on. I think that was really positive. And people did it from, well, some people did it from their exercise bikes, from their home, from their work, wherever it was, people were accessing it wherever they were. And I think that's a really good point. And again, Physio UK this year, the virtual Physio UK was an amazing achievement, in that it achieved more than just being a conference, because you could network. And that, again, quite a number of people saying, I went to that and I've never been to Physio UK before, because I could do it from home. And I think,
accessibility,
and I think it has changed things. And I think our ability, we held way back in 2018, we'd said we want to engage more members, and we held a physio jury, and that was the start of it. But at that point it was still in person, so people had to travel, whereas now maybe we can do that over other issues coming up, and that's it's a self-selecting group of members who are interested in a topic, but it allows them to fully discuss it, and to get a bit more information, and then to feed what they've discussed back to council. And I think that that's all really important in terms of engagement. And I think also looking at some of the events that have happened, there've been some fabulous events from the regional networks, which anybody can go to, not just the people from the region necessarily, because it's been opened up. And I think that ability to sort of communicate across, and for us as council members to be able to attend, I can go to the Southwest event without leaving my
Well, I
comfy
know
chair.
I've spoken at 3 different events, which definitely for an evening, I don't think they'd have bussed me in
No.
in person, but they had me turn up on Zoom to chat to them. They're a bit nice. I think they just wanted some other novel regional accent in the room. But yeah,
Do yourself down.
It's been interesting. It's been interesting to have that, and certainly I think that's where people's comfort with Zoom and elsewhere is going to mean that there's just more accessibility across the board, which we were both passionate about. Then improving engagement, improving conversation, improving takes, all those things that make you furrow your brow and think again and think differently. So that we can then all try to raise standards together and hopefully have a better 2021 than we had 2020. Although as a societal level, let's finish that up then, Alex. And I just wondered if you can give your take on your final take on the year in terms of how we maybe perform, because I'm saying that we will rolling our eyes at 2020 being pretty nasty for the world. However, do you feel you're proud of how the profession has stood up this year?
Very, I have to say, very. I mean, I think we said way back at the beginning, nobody expected what we had, and yet as a profession, we did step up. We stepped up in many ways. We stepped up within the NHS. People coming into the NHS, supporting the services, just making sure in those early stages that there were people on the ground. There were physios joining proning teams. There were healthcare supporters holding services together because the physios had gone, into the main acute hospital. There was a whole range of stuff, and then you get, the independent private sector, where again they were trying to hold their businesses together. I think it's been incredible that actually so many services are still there, that they were there ready to restarting with video consultations, starting all that process. The innovation that's gone on this year in terms of just trying to get access to patients, I think has been incredible. And I think that there's so much everyone has done. When you think about the universities, from the researchers who've just kept things going, the educationalists, the students, all of them have had to change so dramatically, and have done. And I think you've got students who are stressing about placements. Student placements is obviously a big issue, but they've done it. They've done anything. They've been willing to go and do anything. And I think that has just been amazing as well. And I think at this time particularly, it is, if we talk about student placements, it's remembering that offering something is better than nothing. These students are wanting something, and even if it's not perfect, it doesn't need to be perfect at this point in time. Nothing nothing is going according to plan, nothing is perfect.
Yeah.
You know, for them to get some experience of what on earth we're going through, I think is a massive learning experience. And I've said this to a number of people, I do appraisals at work and what have you, and it's like the CPD this year, what have you learned this year is phenomenal. The changes we've made, you don't need to do anything else, but fundamentally the things we've learned that when you look back to a year ago we had no idea about. And some of it is, how do you do a video consultation, the technology, getting the best out of the patient for that. That's a massive thing, because actually we will be using more of this in the future because it works for some people, and I think that's really important. And I think that there's so much learning that's gone on this year, and the fact that physios are still standing at the end of it all, I think is just is amazing. I think any of us standing at the end of this, I think is incredible. And I do also need to pay tribute, to the CSP staff as well during this time, because they went virtual. They went virtual the week before lockdown, so it was planned. Members wouldn't really have noticed anything, and they have also been working their socks off trying to support members, and that's each and every one of them. I mean that I think the focus has been on giving support as best they can. And members might not always have felt that, but the absolute hard work that has gone in there has been incredible.
No, it's been a fascinating year. Is probably a polite way of putting it in many ways, but yeah, certainly the way in which as a profession we've been able to adapt and demonstrate our versatility, which has been talked about many times. And I think that the MDT has always recognised physios as being the problem solvers, and alongside our green colleagues in the OT, of course, but generally speaking, we're the ones that are trying to create solutions, and that's certainly stepped up. You'll witness that step up virtually as well. I think as well, just the way in which, for me, looking forward to the year is hopefully one in which we've come to realise the primacy of rehabilitation and the fact of scaling people's function from where they are to where they want to get to, regardless of our individual, I won't say factions necessarily, but our individual disciplines within physiotherapy or beyond physiotherapy into the wider healthcare sphere, where rehab is central to our purpose. By that commonality is something that has needed to be more primary than the specific interventions that we might deliver, that sometimes are the things that seem to be defining us, be that respiratory physio known for active cycle and breathing and suction-based techniques. Of course, I'm caricaturing again to say a Bobath therapist delivering neuro to a manual therapist in MSK as being like the intervention is somewhat definitive of what is underneath it. Whereas when you think about those three things, what they're trying to do is enhance human function to try and help someone to flourish to their individual goals. And it feels like that this terrible reminder that we've had, this pressure cooker that we've all been in, has meant that it's kind of stripped us back, especially when we then needed to literally not lay us hands for a bit, barring, unfortunately, more suction catheters needed than we'd have liked. But it's then the act of then realizing, well, what is it that's underneath what I'm truly doing, and how is that still useful for me to deliver that over a video consult, has been something that I hope we don't lose that. I hope we don't lose those almost inherent first principles reflections that we've had to have. And certainly
I think it's onto those transferable skills. People have done things they never imagined they would be doing or going back to or whatever, but using those skills that we all have. And you're right, we are amazing actually as a profession. Well, our grounding is it's the breadth of grounding, I think, that allows us to adapt to the challenges that we had, we're still having.
Of course. And so exciting to see what comes of it, and we'll continue to adapt. Thank you so much for those that have tuned in for this, and thank you, Alex, for your time. Really appreciate it. It's been brilliant to look back and forwards, and no doubt we'll speak again in various different contexts. Really appreciate all that you've done for the profession as well. We mentioned off air just before we got going again with this. It's something that you've set a fair precedent for what chairs of council are doing, both in terms of visibility but also your action this year. Really appreciate that, and also really appreciate the openness that you have to discussion with heretics like me and mine at times like this, whereby it's great that nothing seems to be off the table for you, which is certainly a breath of fresh air and something that I really appreciate. So thank you.
No problem at all. Thank you very much. Thank you for having me.
and that is session 85. Many thanks to Alex for coming on the show, for you for listening, and also for all those that have contributed to our podcasts and events through Physio Matters and Therapy Live all of this year, especially the bonus episodes that we did in and around the start of the pandemic, and trying to make sure that we're giving you as much support as we could through Physio Matters and MSKR. It's a very challenging time. Those challenging times, of course, continue, and so we won't let up. We will be, we were in a good position as digital educators and had a responsibility with the platform that we have to try and provide you with as much information to get you through these times as we can. We certainly feel like we've done plenty right, and we've heard from you as such, but there will always be room for improvement. So please do not be shy to get in touch with us on social media at TPM Podcast on most platforms, but also email info@physio-matters.com for any feedback you have, good or bad or constructive, because we really do want to hear about what you want from us to try and make sure that we deliver as best we can for improving and raising standards in MSK practice, whatever it might be. Also feedback, of course, for this episode. We really enjoyed chatting to Alex, and as I mentioned on the intro, I really do feel that there is good reason, and I hope she's proven herself as she has done for many that have been paying attention to her and her team on our elected council, that they are certainly people that are worth giving a shout and engaging with to demonstrate that they are looking to try and involve more voices, as Alex had said on this podcast. And so I think it's testament to the fact that she'll come on the show and discuss as openly as she does and as honestly as she does all the things that we've talked through. So massive thanks again to her and to all of you, and I wish you a very happy new year, and I'll see you in 2020 for more Physio Matters. One thing I regret is that I didn't get her to do our infamous cheesy sign out, but then I think subconsciously, I think I sometimes maybe leave that by accident, because I like saying it. You've been listening to the Physio Matters podcast, discussing physio matters because physio matters. Bye for now.